So those are the differences. I don't know if I explained those very well. We'll come back to them. Okay, so hyperfunction disorders. We're going to start here. We're going to start with the cortex. Number one. So really, you have hyperfunction disorders of the cortex. You have two main problems. You have excess cortisol, which is Cushing's syndrome, and then you can have excess aldosterone, which is going to lead to some of the effects we talked about earlier, the hypertension, hyperkalemia, and so on. We're going to start with Cushing's syndrome, which is really a syndrome which doesn't necessarily describe one pathology. It can describe multiple different etiologies. Let's start with the findings. Almost all of these are explained by cortisol's physiologic and metabolic effects directly. So if you get those down, you'll have no problem with this. They are hypertension. Cortisol is a permissive actor on catecholamines. So its presence leads to hypertension. Weight gain, you're having mobilizing of fats and proteins. You're having, you're creating more energy. You're gaining weight. You have moon phases, truncal obesity, buffalo hump, hyperglycemia. This is an insulin antagonist, right? Cortisol is an antagonist. You're decreasing the uptake of carbohydrates. You're breaking down protein. You're making glucose present, glycemia. Osteoporosis, it's an osteoclast activator. Purple striae, don't know about that one. Immune suppression, that's what we use it for, right? And then psychiatric disorders. Done there. Let's go to the etiologies. Most common cause is iatrogenic. This is us. This is shitty. Let's not do this. Second most common cause is actually called Cushing's disease. This is a pituitary adenoma. This is the disease. The syndrome is, I guess, similar to the symptoms are similar to this disease. That's where it gets its name. So iatrogenic, Cushing's disease, the pituitary adenoma, and then ectopic ACTH, most commonly small cell lung cancer. And then finally adrenal adenoma. It can also be a carcinoma or a hyperplasia, nodular hyperplasia. So how to differentiate between all these different causes? So first, we have somebody come in and we're suspecting Cushing's. We're going to ask them about their steroid use. Are they on steroids for athletic performance enhancement? Are they, on some sort of immune suppression that we don't know about? That's our first step, because that's the most common cause. That's iatrogenic. Then we find out that's not the cause. We're going to do one of these suppression tests. We have high cortisol. We're going to see if we can get it lower. We're going to do a low dose 24-hour a low dose dexamethasone suppression test overnight, and then we're going to check the urine-free cortisol level. Now, a couple of things can happen. It can be normal, which means no Cushing's, and then we're going to have to find other explanations. It can be elevated, which is the other option. Then we have to look to the plasma ACTH. So we have high ACTH. Okay, so in that normal pathway, if we're still having high cortisol, let me think about this for a second. Okay, let's start over. So if this is normal after the dexamethasone suppression test, if that cortisol is normal, then we're no Cushing's. If it's high, it's Cushing's. Now we need to figure out what's going on with ACTH. What's going on? Is there a problem up in the pituitary where it's making too much, or ectopically, or is it not responding to the low ACTH and we have a problem in the adrenal? So how are we going to do that? We're going to check plasma ACTH. If it's high, ACTH is high, we're thinking it's an ACTH dependent cause. So we're thinking pituitary adenoma, which we would do a head CT or an MRI, or we're thinking an ectopic cause, chest CT. That's what we would do there. And this would be something in like a smoker most commonly. If we have low ACTH, we're thinking adrenal Cushing's. This is ACTH independent. So we're thinking adrenal adenoma or some other hyperplasia that we would want to check. An abdominal scan, we would do an MRI or a CT of the abdomen to look for some sort of cause there. Okay. So just to review some of the lab findings that we're going to find here. In a pituitary adenoma in Cushing's, so we have high cortisol no matter what because it's Cushing's. But in a pituitary adenoma, what do we expect the ACTH level to be? We expect it to be high because we have something wrong in that part of the axis. So the part that's supposed to be regulating the adrenal is messed up. producing too much ACTH, leading to downstream high cortisol. Same thing in ectopic ACTH. However, in ectopic ACTH, to differentiate those two, you would do a high dose dexamethasone test, dexamethasone suppression test, and in the ectopic case, you're not having a response, whereas in the pituitary adenoma, you are, because there are just more cells, so you need to have a higher dose in order to get through to them, I guess is how I would say it. Get through to those cells in order to tell them, hey, cut it out, you don't need to keep producing this. Whereas in the ectopic ACTH, it's not part of that axis physiologically, so it's just going to continue producing without even going near the negative feedback. Okay, and then in an adrenal lesion, you're going to have low ACTH because that pituitary is normal, cortisol is high. It is, negative feedback up to the hypothalamus pituitary axis and saying, cut off ACTH. We don't need any more. So you're going to have low ACTH along with the high cortisol. Okay. Wow. It took way too long. It's already 16 minutes. Yeah, 5 to 10 minutes, Martini. I don't think so. Anyway, so treatment. For pituitary adenoma, you're thinking of transsphenoidal surgery or gamma knife. Wow. And you're going to need to replace glucocorticoids for 3 to 6 months until the normal axis function returns. In the adrenal case, you have an adrenal adenoma leading to Cushing's. You're going to do a resection laparoscopically and also supplement, as the contralateral adrenal will be completely atrophied because of the low ACTH. So you need to help that axis get started again. The prognosis is actually good for benign adenomas, 10 years, 90% survival rate. The ectopic producer of ACTH, it depends on the cancer stage. And adrenal cancer, it's not so good. Survival is up to 3 years. Okay, done with Cushing's. Let's move on to excess aldosterone. We're talking hyperaldosteronism. So this is excess mineralocorticoid production. So your findings here, you're going to have hypertension, diastolic hypertension. You're going to have headaches. You're going to have hypokalemia, because that's what aldosterone does. And then also because of the increased peripheral resistance, you could have left ventricular hypertrophy from pumping against that high pressure system again and again and again. And then also you could have renal disease. This is more common in women, 2 times more common, and it's usually a middle age, 30 to 50 years old. So let's talk about the etiologies of this, the causes of this. You have Conn's syndrome, which is primary hyperaldosteronism, and this is due to an adenoma. And this is increased aldosterone independent of renin. So renin normally comes from a healthy kidney in a case of low sodium or low volume. It says, hey, we need more blood, we need more perfusion. And downstream, it up-regulates angiotensin 2, and then aldosterone, which is what we're talking about. We're talking about the glomerulosa. So in this case, you're going to have high aldo, because that's what we're talking about, hyperaldosteronism, and low renin. Okay? So that's the big difference between this next one I'm going to talk about, which is secondary hyperaldosteronism. And this is actually physiologic. But what this is hyperaldosteronism due to low volume. She didn't give really any causes of that, but that's what I was just talking about. When you have low volume sensed by the kidney, high aldo, but you're going to have normally high renin. So that's the difference. One's physiologic, one's not. And then she threw in these other examples, Bartter syndrome, which is also secondary. There is no hypertension or hypokalemia. Don't know. And then Little's syndrome. So Little's is a defect in the NA channel, which mimics hyperaldosteronism. So I guess what I'm thinking that means is you're reuptaking too much sodium, so you're mimicking aldosterone. And then we talked about the 11 beta hydroxylase and 17 alpha hydroxylase deficiencies, where you're shunting down that pathway, or that byproduct 11-doc is also leading to aldosterone-like effects. Okay, so how are we going to work with this? Clinical workup. Sodium overload, which is going to be a, what kind of test? Actually, I don't even remember. So sodium overload, this is a suppression test. We're going to see if we can suppress this axis, the renin-angiotensin axis, with a lot of salt, which would normally say to the kidney, right, the juxtaglomerular apparatus and the macula densa, hey, we have a lot of salt, let's stop making renin. Let's get aldosterone down. So let's try that. So we would have the person salt load, go big, have some fries, whatever. I don't know what she said, but and then we'll check the next day, like we did with dexamethasone test, their urine for aldosterone, cortisol, and creatinine levels. Don't know what that's about. And if we have a response, we're thinking normal, functional, maybe secondary cause, and if we don't, we're thinking primary adenoma of the adrenal of the glomerulosa. Treatment: laparoscopic surgery, spironolactone, which is an aldosterone antagonist, and salt restriction. Okay, done with the cortex hyperfunction. Let's move to the medulla.